Hi, Sandra. We are live. Please begin.
Okay. Good morning, good evening, ladies and gentlemen from across the world. My name is Sandra Black. I'm a professor of neurology at the University of Toronto and a clinical trialist for many years. So I'm very excited and privileged to be chairing this session on really this revolutionary new approach to how we may be able to treat neurodegenerative diseases. We have a mix of some basic science work as well as some clinical trials. And since some of our participants are from Asia, one of them has asked to go first. And so we're going to start with a clinical trial, and then we'll probably deal with some of the basic science models that other people will present. We will welcome questions from other members of the panel, as well as those of you who are listening. But without further ado, I'm going to ask Dr. Chang, who presented some patient work with two patients where he was using focused ultrasound to open up the blood-brain barrier bilaterally in the frontal lobes. So Dr. Chang, some questions that have come forth are, first of all, why did you choose the frontal lobes? And secondly, did you use micro bubbles or was it just opening?
Yeah, I think, as you know, the Dr. Krishna already underwent the small lesion in the frontal lobe, and Dr. Ali Lizai and the group of the United States performed the opening of the hippocampus. But I think if we don't open the big enough, it won't affect anything. So I just want to confirm whether wide BB opening can reduce the amount of the amyloid or potentially the tau protein, and because we are using the new infusion technique of the Incytec systems, we just want to confirm the safety and the feasibility of the wide BB opening in the relatively safe area. We chose the frontal lobe because of the reason, and another reason is by making a same region in this almost same area for each patient, we want to see the real benefit of the removal of the amyloid plaque. So far, we underwent this clinical trial in 6 patients, and we don't finish the clinical trial yet, but we have some very promising results in some of my patients. And we use the definitive for this clinical trial. And because of the regulation of the Korean government, there's a limitation of the using the microbubble. The upper limit is only 1 vial of the definitive. So for the first the clinical trial, the bilateral opening was also somewhat we need to do in a hurry.
And there was a question about the % reduction of PET in those areas. Do you have any information on that yet to share, or is that to come?
Yeah, I think I just changed the presenter file yesterday because we didn't analyze all the data yet, but we recently had one data, and we're surprised about the reduction of the amyloid plaque in the frontal lobe, because by measuring the statistical way, we found that it certainly gives the benefit as we experienced in the animal studies. We had similar findings in patients with Alzheimer's disease, but we don't know all the data yet. We will have all the data probably end of this year, and I can show all the data probably next year.
Very good. Any other questions from the panel or from the people listening? I know Dr. Chang may have to leave us. I just would like to comment, because my background is in cognitive neurology, and that is that if you're going to want a silent lesion, do it in the frontal lobes. Unless you're testing emotion and judgment, especially the right frontal lobe, you can have huge infarcts in the frontal lobe that are not even recognized until somebody has a scan. So probably it is a safe way to start.
Yeah, that's right. We also underwent the comprehensive neurocognitive functions. And as you mentioned, some functions improved, but some function, we didn't see any changes, but we need to see. But yeah, as you mentioned, the frontal lobe is very important structures in the brain, but relatively safer than the other lobes. So that's the reason we chose the the frontal lobe.
Thank you very much. We're going to move along, and this time we're going to shift to the experimental biology, without which none of these trials really would be undertaken. So I'm going to ask, first of all, Dr. Goetz, who's in Brisbane, Australia, to tell us a little bit about the, first of all, just sort of scanning the animal experiments that you're doing in the APA-aged mice is very interesting, because you're going into aging, not just in pathological models, but you have done that as well. And can you give us a sort of sense, scanning along the skull and sort of cortex in the mouse is very different than in humans. How do you see this scaling up to the human condition, where there's this massive kind of cortical region called the hemispheres? What are your thoughts there?
I mean, this will obviously be a challenge, because there's an upscaling, both in terms of the brain size, but also one has to go through the skull. So, I mean, the discussion has come up, let's say, in targeting Alzheimer's disease, basically moving from physiological aging to pathological aging, whether it will be necessary to treat the entire brain. And I think this question is still open. I think it all depends on at which stage one treats disease. So I think the more one waits, I think the larger the brain area is which needs to be treated. But at the moment, when we use a scanning mode, we have approximately 20 to 30 sonication foci, and it's difficult to predict how this translates to a human condition.
So I think, do you want to comment? There was one question about whether there were particular regions that seemed to show more benefit than others, and also did you measure thermometry, the temperature changes?
No, we haven't. What we have been doing is we have been treating, just focusing solely on the aged mice. What we have been doing is we used ultrasound in combination with microbubbles, because this was the technology which we had used in order to treat Alzheimer's mice, both mice with an amyloid and a tau pathology. And so we have been treating what was the question again? Sorry.
Well, it was a question about particular regions and also measuring temperature.
Yeah, we are always, I mean, for most of our studies, occasionally we are focusing on the hippocampus only, but here we have been treating the entire brain. So that's what we call scanning ultrasound. Now, what I haven't shown is that we have not only looked at behavior, we have also obtained biochemical data. So we have dissected the hippocampus. We have been specifically focusing on the hippocampus. So we dissected the hippocampus and performed Western blot analysis on particular fractions, so on the PSD fraction, and found changes to synaptic proteins indicative of an improvement in neuronal signaling. What I have not shown in my presentation is that we have also been performing electrophysiological analyses. So we recorded from brain slices and find that we can restore long-term potentiation. And basically, the changes which we are seeing biochemically are indicative of what we find electrophysiologically.
And when you combine with micro bubbles, it seemed to be more effective. Do you want to just comment quickly on the mechanism?
I think that by opening the blood-brain barrier, I think we add more noise to the system. And something must be in the blood which enters the brain, which has a modulatory function on these improvements which we see in cognition. We have looked at more readouts. We looked at neurogenesis and also at the extracellular matrix. And we consistently see more improvements when we use ultrasound on its own without microbubbles.
Are there any other questions or comments? I know that Dr. Lanenga is going to carry on along the same theme, so perhaps we should just move on. I see we're running out of time. So Dr. Lanenga, you have the privilege of working with Dr. Goetz. So do you want to tell us what you, by adding the scanning and microbubbles, you then added an antibody, aducanumab. And can you tell us a little bit about why you think the combination, again, how this is working, why it seemed to be that the combination of all of these different techniques worked better in your mouse model?
Yes, so we had previously shown that the ultrasound without delivering an antibody was able to reduce plaques, and it has been widely reported that antibody aducanumab is effective at removing plaques when given as an intravenous injection. So the point of the study was to have multiple groups and comparing ultrasound, the antibody, and the combination. So in terms of behavior and plaque removal in the cortex, adding the antibody was better than the ultrasound opening of the blood-brain barrier itself. But all of them, all of the treatments were able to reduce plaques in the hippocampus, although they had differential effects on the behavioral readout.
Any thought as to why it worked even more effectively in the cortex? It had to do with the structure of the cortex versus the structure of the hippocampus?
It could also be how we delivered the ultrasound and the amount of blood-brain barrier opening in different regions, and how consistent potentially the opening was in different regions between the mice would be something I would point to.
Any other questions?
Yes, I have a question. So the drug, in terms of patients, is associated with amyloid-related imaging abnormalities. Have you checked that, or have you seen that also happening in rodents?
Yes, so we see in these old mice some bleeding from amyloid pathology in the blood vessels, but this was not enhanced, it seemed, by the antibody treatment or by the ultrasound. There was no marked differences in this between any of the groups.
Thank you. We'll move along to another model. This is Dr. Kansani. Can you tell us, first of all, it was interesting that you had effects on just wild-type mice and not just the pathological model. Can you comment on that? And a couple of other questions was, how were you assessing immune response? And in your abstract, you mentioned cholesterol being implicated. Can you but you didn't really talk about it in your presentation. So can you comment on both the effect on wild-type mice and immune response and cholesterol?
Sure. So we use the wild-type mice as our control to check on whether a focused ultrasound induced blood-brain barrier opening would by itself cause any behavioral changes, and it actually did. So we are currently investigating whether the effect we see on the transgenic animals is solely dependent on the reduction of the pathology, or their improvement in spatial memory is also attributed to focused ultrasound alone, which would be a great improvement in this modality, being able to stimulate memory improvement just by opening the barrier. So a reason, part of the mechanism that we're looking into was any cholesterol changes that have been shown that are implicated with amyloid plaque reduction in the brain, and in particular LDL. We were not ready to elaborate further in our presentation, but it is in our soon-to-be published paper. And we saw actually LDL increase in the brain after focused ultrasound, which aligns with what is already known in the literature between amyloid plaque reduction and LDL increase in the brain.
Could you also just comment about the fact that, because this was an amyloid and tauopathy model, that you actually saw that the length of the processes of the tau injured processes seem to be reduced by the treatment? Can you just make a quick comment on that? Because that's kind of novel, it seems to me.
Sure, that is a follow-up of our previous study where we used the RTG4510 animal model that only expresses phosphorylated tau. And we saw on that model that only had tau pathology that the axonal projections were less affected by tau by measuring their length after a repeated focus ultrasound. So that is also the case when amyloid is present, and that was also important. Despite seeing a mild amyloid reduction, we still saw the significant decrease in tau, in not only in terms of the axonal length that was affected by tau, but also total tau presence by Western blotting. So that is also a follow-up of our previous findings.
All right, moving along because we're running out of time. So next to Dr. Shima, can you tell us a little, I mean, you were doing, I think, something very novel, which is you were targeting the nucleus basalis and the TARC-A mechanism, receptor mechanisms. Maybe just quickly tell people what D3 is, and also are there analogs in humans for application of this translational application? Maybe just a quick summary for those who may not have seen the full presentation.
Absolutely. Thank you so much, Dr. Black. So in this study, we targeted the basal forebrain and induced blood-brain barrier opening with focused ultrasound and microbubbles in that region. And that was coupled with delivery of a TRAC-A agonist called D3. And TRAC-A is one of the receptors for nerve growth factor, and nerve growth factor is a very potent and is implicated in regenerative processes related to the cholinergic system. That is one of the key neurotransmitter systems that degenerates in AD. And so in this work, we found that D3 allowed for D3 coupled with FUS allowed for an increase in TRAC-A phosphorylation receptor activation, as well as cholinergic function, as well as cognition in a repeated treatment paradigm. So the D3 itself also binds to human TRAC-A. There is a great degree of homology between the TRAC-A receptor in humans and in mice. So the translation there is, and it's already used in the clinic for other applications, and namely retinal degeneration. So the next step will definitely be to to see how exactly we can translate on the levels of identifying patients that would have underlying TRAC-A deficits and would potentially benefit from this treatment.
Very interesting. Dr. Krishna, yes. Can you update us a little bit on your project? I think you have, perhaps from the time of the abstract, you have 6 people, I think, involved. And I guess a couple of questions were all the patients PET positive? And were there any sort of local effects in terms of removal of PET that you could comment on in your human study done in Columbus, Ohio?
Thanks, Dr. Black. So what we're looking at in patients with Alzheimer's disease, opening of blood-brain barrier with infusion of definitive microbubbles. Initially, we focused only on hippocampus, and as the trial opened to other brain targets, we are opening other regions in the brain. All patients were PET positive for amyloid. And what we have found is that the changes in amyloid after 3 treatments has varied. And so when we look at the whole region of interest that was treated, the numbers range from 3% to 8%. And if you look at voxel-wise changes, the numbers vary from 3% again to 20% in the region where you open the blood-brain barrier.
All right, thank you. We're fighting against the clock here. I guess could just quickly, there were some cognitive and behavioral consequences, adverse events. Did they resolve in the subjects as they were followed, just quickly?
Yes, most of them resolved. In one patient, we still continue to follow changes in their working memory.
Okay, thank you. Dr. Meng, you will finish off the session. And can you just quickly update where things are with respect to the projects you've been involved with? I think there are now 9 subjects with multiple openings, and just maybe answer whether there have been any adverse events or sort of how it seems to be unfolding in this follow-up to the previous first study in man. that was just concentrating on the frontal lobe. So please just give us a quick update, and sorry for the short amount of time. We're going to be closing soon.
No problem. Thank you. So we've been conducting a very similar study looking at blood-brain barrier opening in hippocampus as well as regions across the default mode network in patients with mild to moderate Alzheimer's. So we've treated 9 patients. We have found no serious adverse events, but in some patients there is a transient period of increased confusion that we think may be related to some of the anesthetic effects of having gone through the procedures. But these as I mentioned, these are transient, and patient overall have tolerated the procedure quite well. So we are currently analyzing and planning on reporting our study results soon. So that's kind of where we are at right now.
All right, I think we're 1 minute away from closing, or is that correct? I think so. So that let me thank everybody for being here, for your tremendous contributions to this really revolutionary approach to neurodegenerative diseases, maybe across different neurodegenerative disorders, and finding ways to access them. So thank you all very much. You are pioneers, and it's a privilege to have been able to chair this question period. All the best. Take care, everyone. And as they say,
Thank you.
Keep safe and stay negative. You have to be in this current era to know what that means.